Have you ever woken up feeling like your spine was replaced by a rusty coat hanger? Morning stiffness, aching back, and you're under 40? It might not just be aging early. You could be staring down the spine of ankylosing spondylitis. Hi, I'm Dr. Rezaian. Before we dive in, a quick note. This video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check everything with trusted sources. Let's break it down. Ankylosing spondylitis, or AS if you want to save a few syllables, is a chronic inflammatory disease that mainly attacks your spine and sacroiliac joints. Over time, it can actually cause your spine to fuse. We're talking bamboo spine, rigid, inflexible, and painful. Let's talk numbers. AS affects up to 1.4% of people globally, and it's way more common in men, sorry guys. Symptoms usually begin in the late teens to early 30s. And there's a genetic fingerprint that's often present, HLA-B27. If you've got it, your risk jumps significantly. AS targets the entheses, those little connection points where tendons and ligaments attach to bone. The immune system sees trouble, triggers inflammation, and pretty soon you're eroding old bone and laying down new bone in all the wrong places. The result? Stiffness, not strength. Driving this chaos are inflammatory messengers like TNF-alpha and IL-17. And here's a twist. Some people with AS have silent inflammation in their gut. So yeah, your intestines might be whispering trouble to your spine. Picture this. Back pain that creeps in before age 40, gets worse with rest, and makes mornings feel like molasses. That's classic inflammatory back pain. Hallmarks include morning stiffness over 30 minutes, pain that improves with movement, nighttime discomfort, limited spinal mobility, but AS doesn't stop at the spine. You might also experience peripheral arthritis, enthesitis like heel pain at the Achilles, dactylitis or sausage digits, uveitis, eye inflammation that causes redness and blurred vision, inflammatory bowel disease, even heart and lung involvement. It's a full-body experience. So how do you know it's AS? Enter the ASAS criteria. If you have back pain for over 3 months and you're under 45, we look for imaging showing sacroiliitis or a positive HLA-B27 blood test, plus a bunch of other SPA features. X-rays show damage late in the game. To catch it early, MRI is your best friend. It can spot bone marrow edema before structural changes even happen. Lab results? A bit of a mixed bag. HLA-B27 is common but not exclusive. Inflammatory markers like ESR and CRP may be elevated, but not always. And here's the key. AS is seronegative, meaning no rheumatoid factor or anti-CCP. That helps rule out other types of arthritis. Before you pin it all on AS, you have to rule out the imposters. Mechanical back pain, rheumatoid arthritis, psoriatic arthritis, DISH, diffuse idiopathic skeletal hyperostosis, infections causing sacroiliitis, and even IBD-related spondyloarthritis. Now let's get to the good stuff, treatment. AS isn't curable yet, but we can absolutely control it. The strategy? Think in threes: movement, medications, and mindset. Physical therapy isn't optional, it's your armor. Exercise reduces stiffness, boosts posture, helps you breathe easier, and may even delay fusion. Ties, stretching, strengthening, postural training. Swimming and yoga, fantastic choices. Motion really is lotion. Here's your pharmaceutical playbook. NSAIDs, first line, first defense. Meds like naproxen, indomethacin, and diclofenac are your starting point. They reduce pain and inflammation and may even slow bone changes. But beware, long-term use can cause GI bleeding, kidney issues, and hypertension. TNF inhibitors, game changers. If NSAIDs don't cut it, enter biologics. These include Enbrel, adalimumab, infliximab, golimumab simponi, certolizumab. They block TNF-alpha, a key driver of inflammation. Side effects: infection risk, TB reactivation, and rare neurological issues. TB and hepatitis screening are mandatory before starting. IL-17 inhibitors for TNF failures or skin plus spine combo. Options: secukinumab and ixazomab Taltz. Great if you also have psoriasis. Less ideal if you have inflammatory bowel disease. JAK inhibitors, the oral option. Pills like upadacitinib, tofacitinib, filgotinib, pending approval in some regions. They're effective, fast-acting, and convenient, but carry risks like blood clots, infections, liver enzyme elevation, high cholesterol. Regular lab monitoring is a must. Conventional DMARDs limited but useful. Methotrexate and sulfasalazine don't help the spine much, but they can work if you've got peripheral joint involvement. Corticosteroids short-term fix only. Oral prednisone helps during bad flares, but it's not sustainable. Long-term risks include osteoporosis, diabetes, and weight gain. However, local joint injections, very effective for targeted pain. Let's not forget the stuff you control every day. Quit smoking, it accelerates spinal fusion. Stay active, motion keeps inflammation in check. Optimize your posture, especially if you work at a desk. Get a DEXA scan, osteoporosis is common. Watch your eyes, sudden pain or blurriness, that could be uveitis. Ankylosing spondylitis is no joke, but you are not powerless. With the right meds, movement, and mindset, you can live fully, flexibly, and fiercely. And don't forget to like, subscribe, and stretch.